your home. Dr. Shebak and Yasmeen, please go ahead, share your screen and start your presentation when you're ready.
And present, yeah. Hello, everyone. How are you guys? It's always my honor and privilege to present at the Muslim Mental Health Conference. I'm on time this year. Last year, I think I missed my day by a day. But this year, alhamdulillah, we're ready. And we're excited to present. With me is Yasmeen Khan. She's actually the vice president of the MOVE organization. And she really worked very hard on this presentation with me. And she very excited to present with me today. This topic is extremely important because different cultures have different backbones, right? They're structured completely differently than one another. And so it's very important that as mental health professionals and mental health providers that we not only understand cultures, but we work within the patient's cultural framework in order to create a therapeutic alliance. So with that said, I'm going to go ahead and give it over to Yasmeen. And I'm going to be presenting a little bit later in this presentation.
Thank you. Okay, so let me just see if this is working. So we started this study off by having 3 case studies, and we had 3 patients that were seen in the clinic who presented with disorders or problems that otherwise if they weren't Arab, it would have kind of changed the way that it was seen. So first we had Mona, who was a 46-year-old Arab American Muslim lady, and her daughter was participating in mental health treatment at the clinic. When she had brought her daughter in, she was convincing the psychiatrist that she doesn't have any problems and not to believe what her daughter says, to sway his opinion that there's nothing wrong with her. She didn't want anything to get back into the community. In this community specifically, there are a lot of Arab American Muslims and Arab Muslims. So the thought of having a problem be heard in the community and the reputation being tarnished, that was the biggest worry of this particular mother of a patient. Next, we saw Samar, who was a 32-year-old Arab American Muslim lady, and she was experiencing some disorders based on her husband taking a second wife. He did so based on Islamic law, which permits polygamy, so he could take up to 4 wives. He took a second one, and so his first wife was experiencing neurological symptoms and somatic symptoms. If I remember correctly, she was completely mute. She could not communicate whatsoever. So she is currently receiving both psychiatric medical care as well as therapy. And then Angela, who is a 19-year-old Arab American Muslim lady, she has a history of social isolation, poor eye contact, and she fixated on something in her initial appointment called maladaptive daydreaming, which doesn't have any kind of medical basis, but she was convinced that she had maladaptive daydreaming because she would hear things and she would just be in her own world when there was really nothing happening there. She was later diagnosed when she came into the clinic with autism. So she went for 19 years without any diagnosis of autism, which upon her ADOS testing, it was very obvious. So this is relevant to the Muslim population because as we had said earlier, there are 2 primary cultures. There's honor and shame, which is when actions and self-worth are dictated externally. So we see this in North African cultures, Middle Eastern cultures, South Asian cultures, where how you are perceived by others is how you should determine your actions and how your self-worth is determined. That leads to you living up to your reputation based on what other people see of you. Whereas dignity and guilt cultures are what we primarily see in the West. And that's when your actions and self-worth are dictated internally. You aren't as worried about how others perceive you. You act and behave for yourself. We can also say that in some Catholic-based cultures, we can see dignity and guilt because they live, because Catholics live for redemption. They are seeking salvation for themselves. Islamic cultures are doing it so that you are, or not so much Islam itself, but the cultures in the Middle East do so that you see how others perceive you. So this kind of ties into acculturation because, especially in a primarily Arab American community, how you assimilate with others, how you're integrated determines whether or not you're going to be marginalized or separated from that community. So you're always having to live up to a certain standard.
I want to jump in here and just kind of run through this again, because this is extremely, extremely important. So what I always say is honor and shame cultures, your moral compass is external in those cultures. Now, religion and culture, they play a symbiotic role. But for example, there are cultures, for example, in Latin America that may be Catholic, but they operate on an honor and shame model. Furthermore, in the Middle East, right? So Middle East, like she said, North Africa, Sub-Saharan continent, and others, they operate on an honor and shame, meaning the external compass, your reputation. We have a lot of words in Arabic specifically to even explain these things, whether it's sa'ird or karami or sharaf, and all these things that are extremely important words in the Arab language to explain this concept of honor and shame. When two cultures meet, they go through a process of the culture that came from a homeland to a new land goes through the process of acculturation. And there are four distinct places that person can end up. So I'm coming from a country or a civilization that's honor and shame, right? Let's just use that as an example. When I arrive to the new shores, I can either assimilate, so completely rid myself of my culture, my heritage and traditions, and just go ahead and join the dominant host culture. I can integrate, meaning I can keep my identity and also integrate into the new identity, and therefore I have kind of like a hybrid. I can marginalize, become marginalized or marginalized, and not keep my culture and not take on any of the host culture either. And then that leads to sense of marginalization where you don't identify with either culture. Or I can separate and go into an ethnic enclave and continue life as normal. So from these four models, integration is, I like to think of that as the goal, so that you don't give up your identity, your traditions, your culture, etc., but you also are able to integrate and accept and learn and teach within the new cultural framework that you've entered. I think of separation as my grandmother, right? When she came to this country, she separated. They went to the ethnic enclave, and she sort of continued her life as normal as what it was when she was in Lebanon. So that could be healthy too for certain people if they're older and they have their social networks and things like that. To separate into an ethnic enclave, it's not necessarily unhealthy. It might be more unhealthy for a 20-year-old to do that. But someone who's older that's coming here as an immigrant, that's an option that happens. Assimilation, we can all kind of know what that is. That's you give up everything, you become highly critical of your home culture and very, very receptive to the host culture. Marginalization, you could think of someone who maybe came as a refugee and is in a refugee area where they put you in the middle of nowhere and you become kind of lost. And we can kind of almost see that archetype in our head of people that deal with that marginalization, and that's probably the least healthy, least desirable outcome. And I also wanted to also touch up on the issue of cultural sensitivity and how I saw it work out in the clinic. Is when the one when the lady Samar had mentioned to her therapist that her husband got married to someone else under Islamic law, the therapist became very confused and didn't know what was going on. So this is a therapist that's not very well versed in the culture. So I had to sit down and explain what that means, what it does, and how do we navigate it so we don't cause a lot of new problems. So it's also important that we, as Muslims, Muslim Americans and as Arab Americans, if we are Arab, but Muslims in general, we share a lot of similar cultural frameworks, with each other, not just because based on religion, but even region, right? We said that culture is not just, it's definitely not just religion, it's regional as well. And our regions share very similar culture. And so we have the task of educating our peers on what these things are, because our peers can have some culture shock if they're dealing with a culture that they're really not used to, and they may interact or react in a way that may stifle a therapeutic alliance. So we always want to be the ones out there educating and making sure that our peers understand what is going on in a very neutral way, and in a way that will help them form that therapeutic alliance with the patient and understand the culture, right? So there's a lot of talk about diversity in the workspace and stuff, but diversity is not, that it's not just, the token diversity. We actually have to be on the front lines and educating our co-workers on these cultural differences in a way that enlightens them and allows us to create a better environment for patients that come from our background. So that's extremely, extremely important on us as Muslim providers. Oops.
So going back into that second case that we had seen, there is an acceptance of polygamy in Islamic and Arab traditions. So when that therapist was unfamiliar with that being a concept, she didn't know how to go about treatment with that patient, especially being that the patient couldn't talk whatsoever. So I think what came out of that, like Dr. Shady had said, was that regardless of the cultural framework that you belong to, it is our right as or our duty as providers to understand all types of cultures, whether, even though we come from honor, shame ones, to understand how dignity and guilt ones work too, so that the appropriate care can be provided. Back to the third case study with the autistic patient, Angela, just upon the first test that was given, which was the ADOS, she scored so that it was clear that she was autistic, and she had an ADHD profile, which wasn't diagnosed either. She went to school in the Arab American community and had been seen by certain school professionals who were unable to refer her to a proper provider. So it's problematic that she wasn't given the proper referrals or treatment from a young age, because she went 19 years without any knowledge of her condition whatsoever, and that has had effects on her now.
So that shows that apart from just culture, immigrant communities may also have an issue of access to certain care, or even being conscious of certain diagnoses and care, that something can go undiagnosed for 19 years. In a rarely obvious case, this is somebody who, very, very much meets the criteria for autism spectrum disorder, and it went 19 years. It really struck with me that, for 19 years, the thought of that didn't even come to anyone's mind. So that's another thing. Don't assume that the diagnosis that someone has when they come to see you in a clinic are correct. Always reevaluate, especially if you're working in an underserved community, because a lot of things can go undiagnosed and missing due to lack of access. So that's important. Okay. So what's the relevance to mental health? We discussed some of that already. But we know that religion and spirituality can be protective factors. Certain Islamic Sharia and law serves as a protective factor for example, suicide. But just because there's a protective factor against suicide, it doesn't mean that the patients still don't suffer with suicidal ideation and suffer tremendously with depression. So screen. Don't take it for granted that someone may have certain religious obligations and maybe a religious person, that they're not only that well, they can still commit suicide, obviously, at a lower rate than others, but they still can, but that they're still not suffering tremendously from their mental health condition. Culture. So culture can be a protective factor because it gives us a place to belong. It gives us a community. But it could also be stifling. For example, in the case of the polygamy, right? Someone is, in that specific case, the cultural thing was not very helpful to her, that specific cultural thing. But always be sensitive to people's cultures instead of disparaging. So if you have someone who's an immigrant or something of that nature, to tell them, don't worry about what other people think. Don't worry about shame. Don't worry about any of that. Well, that's not going to work because they're structured that way. The culture is that way. So to work with the framework of the culture instead of trying to, disparage or take it down or tell them that don't worry about these things. No, well, they are worried about these things. So if they're worried about these things, then you need to work on a way to that, not that says that that works with what they're worried about to provide a solution that's attainable, not a solution based on a dignity model. So oftentimes mental health providers will provide solutions that are based on a dignity model culture. Do you, be you, don't worry about anything else. And that is not going to work. You may think it'll work. We may hope that it will work in alleviating someone's suffering, but it's not going to. And we've seen that time and time again over the last couple of years. Many of the presentations I've given have been around this topic because it's so important that it's the best way to treat someone is by really understanding where they're coming from and not creating more cultural barriers to that person. And like I said, culture can be an impediment to mental health. Both dignity models in the West can be impediments. Do you, be you, and the person ends up not really caring about anybody else. And in honor and shame cultures, it could be an impediment. You're worried too much about what other people think and do and say, that you don't seek the proper help and care that you need. Just like that first case we mentioned where, the mother came in and said, don't believe anything this patient says, to protect, basically she was trying to protect the sanctity of her family. So understanding that, putting people at ease and providing that care is of the utmost importance. And there, as a therapist or provider, you're going to challenge certain ideas that patients have, and that's okay too, but do it from the framework of cultural awareness and sensitivity and appropriateness, rather from a position of power or a position of bias towards one model over the other. So I think that's where the relevance to mental health really, really shines in these cases. Some more clinical implications. We wanted to discuss a little bit on these topics here. So autonomy, right? So that's something extremely important. It's a very important ethical consideration for mental health providers. You want to make sure that the patient's autonomy is respected, that they have a sense of personal achievement, and sometimes culture and tradition may impede that, where families become too involved. So with honor and shame cultures, especially in the Arab American Muslim community, the sense of individual is a little different than the sense of individual in some Western traditions. So families are more likely to be involved. They will call you, and you just have to be open to that, understand that that's going to happen a lot more than in other populations, and be firm with the privacy things, but also you're going to be doing some counseling for family members as well, oftentimes, to help them deal and learn and understand what their family members are dealing with. But autonomy is very important. Beneficence, imperative to encourage cultural and spiritual protective factors. Non-maleficence, you cannot encourage patients or family or community members to abandon their cultural values. That's what I was talking about in the last couple slides, is not to isolate them from their culture and from their community, but rather find a way to integrate them into the host culture and also keep the protective factors alive in them, instead of demolishing everything that they hold dear and starting from scratch, if that makes sense. And justice, obviously patients cannot be exempt from treatment based on cultural differences and different religious frameworks from mainstream American culture.
Just one thing to say. One thing that struck me when seeing these patients was that if a patient says that they're suicide or that they're depressed, but when you ask them, "Are you thinking of committing suicide?" and they say no because their religion forbids them from it, that's something to be encouraged. That if they don't want to commit suicide because of that religious protective factor, that's a good enough reason to encourage it.
To encourage it, because it is a protective factor, but to also recognize that just because someone says they're not going to, it doesn't mean that they won't, and it doesn't mean that they're still not suffering. So that's something to also take into strong consideration. Right, so we can't just be like, oh, okay, well, they're good. No, they're still, the suffering can still be the same. So Arab American Muslims are a diverse group of Americans. They're all at different stages of acculturation. The Arab American Muslim community has been around since the early 1900s. Actually, my grandfather's father came here in the early 1900s to the various parts of the US, Canada, and then went back to the Middle East. So my family really came in the 80s, late 70s and 80s, but we do have roots here that go back to the early 1900s. So there's recent immigrants. There's first generation and second generation American families as well that have been part of, and there's, like I said, ones that have been from the 1900s. There's also different flows of immigrants, meaning, you know, there's a very established Lebanese community in Michigan, very established Chaldean community. And then there's more recent immigrants that come from Iraq and Yemen. And there's also actually a very old established Yemen community as well, Yemeni community. And very recently we have Syrians coming in. So, and they all differ. And so they may have an honor and shame structure or what have you, but there are very fine differences between them, the cultures themselves, and how they present themselves and what they hold dear and what kind of traditions they have. It's not just a one size fits all. It's not, you can't clump someone, oh, well, they're all Arab or they're all this or they're all honor and shame. Yeah, they may be, but there's still going to be nuances and differences, and very, very important differences in how the family's structured. And do they have tribal affiliations or not? Are they Sunni? Are they Shia? Are they Christian? Are they Druze? There's many, many different faiths and people that come from the Middle East. So it's important to really study your patient's culture, what they hold dear, and not to box them in with everybody else as well, because there is still individuality, right? Even in collective cultures, there's still a sense of individual. So to also understand don't let the cultural theories and things like that also cloud your knowledge of the individual that's in front of you. What's interesting is the amount of diversity in Middle Eastern cultures that exist in the area that we serve. As I said, with the Lebanese, the Iraqi community, the Yemeni, the Palestinian, the Syrian, the Chaldean, and many, many others, and Muslims and Christians and Shias and Sunnis. These things exist, and we should recognize these things and discuss it if the patient feels comfortable discussing their culture and religious and ideas with you. So just as a recap, extremely important to understand culture, extremely important to understand the frameworks of honor and shame and dignity and guilt, not to disparage someone or discourage someone's cultural traditions, but to understand them and use them in a way that's symbiotic with their healthcare, and to provide culturally appropriate solutions. As I said before, sometimes we provide solutions to people in a one-size-fits-all or from one model, right? We often are trained and give solutions from a dignity and guilt model even when we're serving a predominantly honor and shame culture or recent immigrants. And it's important to know what generation your patient is here, because the first generation may be still in the early processes of integration, while someone who's second or third or fourth generation may be integrated or assimilated. So also not to stereotype people based on their ethnicity and culture, and to understand where they are in the process of acculturation. I think that was the last slide. So I don't know if we're doing questions and answers now or if we're going to wait.
Yes, we can move on to question and answer sessions now because Dr. Zidan unfortunately is not here. So while we're continuing question and answers, we'll continue to wait to see if he does arrive. And also, Dr. McRae is not here. So I would like to go ahead and provide a brief feedback to the presentation, and then we can go ahead and start with the questions. I already see questions coming in the chat box. Please go ahead and put in all your questions in the chat box or use the raise hand feature, and I will be happy to unmute you one by one, and we can hopefully have a very interesting discussion. I first want to start by saying I think really well done. I think I really appreciated the fact that you used live case examples. I did think that there were a few things that may require further clarifications, and I'm going to go ahead and comment upon those and let you start with first answering those questions, and then we'll take the questions from the audience. The first thing I was very interested by was when you talked about an honor and shame culture versus a dignity and guilt culture. I was wondering if you could give an example of what a response would be that would be honor and shame mediated, and how it would be different to that which is dignity and guilt associated. You can use examples of any of your three cases when you do that. The second question I had was, I did take it to heart that you said when people say that they're non-suicidal when they actually might be, and we do understand it's a religious belief and we should encourage it. I was wondering if you or anyone else in the audience had a more religiously palatable way to ask that question, where we wouldn't use the word suicide, or it would be a better way to ask that question so that we as psychiatrists or psychologists can still analyze where they're at in terms of their suicide risk, as that is the most important in our population. Get into the culture shock mode as a therapist. What are some of the ways that therapists who are non-Muslim but dealing with Muslim clients can make it more palatable for themselves and their responses so that they can understand the culture shocks better? And the very last thing I would like you to comment upon is for the person who was diagnosed with autism at 19-year-old, what was the prognosis and how do you think it would have been different if they were diagnosed earlier? And you can go back and forth between Yasmeen and yourself, and I'd like to ask, see what your response is.
These are excellent questions. Let's start with the honor and shame. So when someone comes in, it doesn't necessarily manifest as a question from patients, but it's an attitude, right? And so someone will come, and so the lady's mother that came and told us, don't believe anything she says, you know, she's going to exaggerate, right? That's an attitude that you got to read through that. She's not trying to hide anything per se. She's trying to warn you that there's some things that may be embarrassing to the family. So what you want to do is alleviate it. So what I did is I sat down with her and I explained to her the great deal of privacy that we take. So, you know, we take privacy very, very seriously here. We understand that you guys are a wonderful family. You're well known in the community. You know, I've gotten to know you and your children, if you had a long-term relationship, which I did with them. And there's nothing that you need to be worried about as long as no one was physically or sexually abused. You know, if it's just clinical symptoms, I need to know what's going on so we can best treat them, and we will involve you as much as we can with this, and your privacy and your sanctity and all that will be preserved. Basically, you're trying to make sure that the patient understands that the news that they give you and the things that you discuss in session will not make it out to the community. Because another thing that happens in honor and shame cultures, and even in a close-knit community, is there's a lot of word of mouth, a lot of talk, a lot of things that can happen. So people are weary and afraid to put out their business, so not a lot of people find out about it, because it's a tight-knit community. Everybody knows everybody. It's like a village, right? So you just want to make sure that you go the extra mile in explaining how important privacy is and how important it is to know clinically what's going on very honestly. so that you can provide the best treatment so that the patient does so. And you want to explain to them that if they don't get the proper treatment, they may get worse, and then they may be acting out in public, etc. So really just providing a very sensitive kind, as you said, in a frank conversation is extremely important. That you may not have to go those routes if you're treating someone in a more integrated or assimilated part of the country. Your other question, the second question was, sorry, what was, just
the
remind
suicide.
me the topic. Oh, suicide. So with suicide, what I do is I go through a series of questions, first trying to determine if religion is important to this person's life. Just because you're in a Muslim community or Arab American community, as I said, there's first, second, third generations. There's people who are religious, people who are not, people who are Christian, people who are not, people who are atheists, people who are not. So it is still, there's a still diversity of faith in any faith-based community. So you want to ascertain how important the religion is to them. Are they religious people? Or are they not? If they are, you simply ask, do you mind if we talk a little bit about faith and religion? Is that something that you adhere to? What faith is it? Do you think God is responsible for your mental health? What kind of things do you believe faith does for somebody? So you want to get their idea on what religion is to them and how important it is to them. Now, if it's very, very important, then you ask, well, do you feel, you do your mental health screening, screen for the depressive symptoms, suicidal symptoms, which you've probably already done by this point, and then ask them. Then you can ask them, would you ever have thoughts about hurting yourself, just like you would anyone else? And if they say absolutely never would I ever hurt myself because it's banned and it's forbidden and whatever, that's a good sign, because they may not hurt themselves at that point, because they're telling you like that they're being honest that this is not something I can ever do because I don't want to be doing anything against the religious tenets. But that's where you start really have to screen for thoughts, because they may not do it, but they may still be suffering tremendously with suicidal thoughts. So then you can differentiate and say, well, the action, I know you won't do the action. I know that that's against your culture. If it is, some might say, well, no, it's not, I don't really care about the religion and I would hurt myself if I had to. But if someone is adamant, then you say, I understand that's against it, but do you ever have the thoughts? Do you ever feel like you want to hurt yourself, or do you ever feel like you just want God to take your life and just so you could relax and die? And oftentimes they'll say yes. They'll say yes. Not most of the time. Most people are not suicidal all the time, right? But oftentimes you'll get an answer like, yeah, yes, I do have those thoughts. I do have the thoughts of just wanting to be ended, just wanting things to end, but I would never do it myself. And that's a big glimpse into that they're suffering tremendously from mental health and depression and anxiety and these types of things. So that's so like a traditional like assessment, and you just want to go down a list. But with some of these patient populations, the conversation is extremely important. Third question was,
how would a therapist or a psychiatrist adapt to a culture shock?
That's even me. I have culture. I'm very traditionally Arab, right? I grew up in an immigrant household. I hold a lot of traditional values, speak fluently. And there are things, for example, when I'll see someone from a different Arab ethnicity or different community, or different culture in general, that there is a tremendous amount of culture shock that I can go through. And the best way for us to address that is to try to keep as neutral as possible. So prepare yourself before your appointment. Prepare yourself that something may be said, and you're going to have the right, you're going to go like that, because they're going to pick up on all of your body language. And me, I have a lot of body language, so I've had to really control that. And prepare myself before an appointment, and different things will require different preparation. So if I know if I look at the schedule and I see someone is coming from, and has a name that sounds like it's coming from a certain culture, I may prepare myself beforehand, just so that if they say something, I'm not gonna act shocked or I may be internally shocked or internally confused, but you want to try to stay neutral. So if someone says something like this, the lady we discussed today, so she was seeing a white therapist, and you know, God bless her, she was an excellent therapist, but my husband just got married to a second wife, Islamic law. That's like what? Oh my God, that's terrible. Yeah, so it might be terrible or for that patient, but you don't want to say that. You don't want to jump. You don't want to give your reaction immediately. A better way to respond would be, oh, okay. So tell me more about that. Tell me what do you mean he got married to a second wife? How does that work? Is it through the courts? Is it through so ask the questions instead of acting shocked, because we get a lot of shocking things. So think about it in terms of someone comes in and tells you I was assaulted when I was 5 years old from so-and-so. That's shocking stuff, but you don't jump and say, oh my God, and you act all shocked and things. You're there to calm down the patient, so you don't act that way. So similar with that case, which we often see in mental health, is cultural cases where something happens that's outside of your norm. You don't want to react too much. You want to react by asking questions, by getting clarification, and then always touch base with someone that you know that may be of that culture. So thankfully, we all work in the same clinic, so I touched base right away, and I educated the person, and decided that I did move the patient to another therapist that is more culturally sensitive. But that's not necessary. You don't always have to move someone to someone of their own culture. You can simply educate the person that's treating them. But in this case, there was other things that made me decide to switch the patient over. But ask, clarify, read, do research online to figure out what's going on before you create a reaction. So maybe your first appointment, you have all these shocks and you don't react to them. You're just clarifying, and then you do your own research on your own, and then you start coming up with a solution for the patient that's realistic for them, and understand where they're at in that situation. So always understand, clarify, ask, and us as Muslims and Arab and people of different cultures in our workspace can be that backbone in a positive way. Oftentimes we hear about wrong diagnoses or tensions in the clinic and stuff. Well, we can be a source of releasing that tension and being people who educate our peers and serve as a positive impact in our workspace and our patients by being the backbone to that clinic. And oftentimes we have to check our own biases. So some of these traditions and say, oh, these are all backwards. This is all terrible. No, I mean, we cannot be elitist either. We have to understand who we're working with and provide the solutions, because if we're going to do that, then we're going to miss out on the ability to help people and help them navigate their very complicated situations. So we also have to check our own notions and elitist notions, etc. as well, always.
And then the last question was for probably different. I'm not a provider, so I can't say, I'll leave that to Dr. Shady as to how her prognosis would have been different. But I do know that with her testing, she was diagnosed with mild autism. Just more in her profile, she did endure some emotional abuse and sexual abuse when she was in school and had to transfer a few times. So that took a toll on her other diagnoses that she has, but I'll let Dr. Shady explain that more.
So I think that with that case, it would have changed by having her in more special programs in school, so she wouldn't have to have dealt with bullying, because you have someone who's fairly, I think I diagnosed her with moderate, I think, autism, but someone who has they're very socially awkward, socially distant, and they're bullied and they're put in normal classrooms, with mainstream, and they don't have any secondary help, no paraprofessional with them, nobody to help them, guide them through the school. So if this person had been diagnosed at the age of 8 or 9 or 5, those types of support networks would have been put in place a lot sooner and a lot earlier than they were. The other thing is some of this other things that she was suffering with, like maladaptive daydreaming, which I still don't understand what it is. Sorry, give me one sec. So some of this stuff was treated as if it was psychosis and bipolar disorder, and was treated with heavy doses of meds, right?
That was a very quick therapy session, by the way. The one you did just as you moved out.
Sorry?
I said that was a very quick therapy session, by the way. The one which you did by putting us on silence. It worked very quickly.
Sorry. So she, you're treating someone for psychotic symptoms, which they're really not psychosis. They're just intense daydreaming of her being in different fantasy areas and fantasy places, right? Very childlike daydreaming, and it's being treated as psychosis. While if we had caught this earlier on, she may not have gotten to that level, because she would have had the support systems put in place, and she would have had the therapy put in place, and she would have had the proper classroom accommodations put in place throughout school. So she would have had to suffer with either poor grades or bullying or any of that stuff that she did. So it does make a difference how early you catch it. At 19, right, there's not much. It's basically not much you can do, too much you can do at that point other than proper therapy. But at 19, it basically gave her peace of mind. So that's what we gave her in that sense. But yeah, you definitely wish that you catch this stuff a lot younger.
It's wonderful that you finally caught it at 19 and all. It's very, very good. I do see a few questions in the chat box. I'm going to throw them out to you one by one. Also, an announcement for the audience, all the attendees, if you have any questions, please either use the raise hand feature and I can unmute you, or you can use the chat box to type them in and I will read them out for you. The first one is from Zarina Nadir, my friend and our very wonderful host last year. She says, just curious, do non-Muslim Arabs seem to acculturate better in the US than Muslim Arabs?
I'm not sure. But I will say this: if you have a strong community behind you, you're always going to feel a more sense of belonging than if you're isolated. So I think it depends more on how close knit the community is. You know, someone who's, like I said, a refugee in the middle of South Dakota or Minnesota or something like that may feel marginalized. But if they're a refugee and they're close to a community of their own, they may have the ability to integrate and still have a reach for their culture and a reach for the host culture at the same time. There is some research about Muslims versus Christians and how they acculturate, and it seems to be that it's pretty similar. It's a pretty similar process. But as far as Arab and non-Arab, I'm not sure. It really would. I would say that it would depend on the community and how strong the community is and how well aware they are of each other and how much support system someone has. But I can't answer definitively because I haven't read anything on that.
I wonder if I can take the liberty of posing this question to Yasmeen as well and see what it is from a woman's perspective in terms of acculturation of non-Muslim Arabs versus Muslim Arabs in the US.
So my experiences, and this is for non-Muslim Arabs, so
Muslim Arab,
non-Arab
Muslim.
I'm sorry, is the question asking about non-Muslim Arabs or non-Arab Muslims?
Non-Muslim Arabs. So
Arabs. I misread the question. I'm sorry. Okay, that's fine.
So from my experiences that I've had, we have a large Chaldean community in Michigan, and so those are Iraqi Christians. And I'm not sure so much from a female perspective, but I've seen that they've been able to assimilate a bit better and integrate actually better than Muslim Arabs. There are things that they're able to relate to better with mainstream Americans than Muslims are. So I think that it is actually easier for Christian Arabs to integrate, and they don't feel as marginalized, especially because here, since that Chaldean community is so big, they do have their roots here, and then they're also able to, in schools and in a workforce, still integrate with people who are not of their community, knowing that they have that backbone to fall back on.
Now, I do want to touch base that there are different types of Muslim. Sorry, I misunderstood the question. I thought it was non-Arabs versus Arabs. Sorry. So there are different non-Muslim Arab populations as well. So, for example, you can be a Chaldean. They're not really Arab, they're Chaldean, but they have a lot of the Arab culture and language and things like that. But they have a community, right? But let's say you're a Syrian Christian that just came to the United States and you wanted to go to an Arab community, so you end up in Dearborn or something, and it's all Muslims around you. Well, that's not that's going to cause some problems. So it always depends on the situation of how you got here. Right? If you're a Christian from Egypt, for example, and you end up in somewhere that has no Egyptian Christians, so that might create some issues. So maybe on the whole, the Christians have an easier time integrating and may actually assimilate. So we know what assimilation is completely abandoning and finding the new culture. So they may have on the whole, but on an individual level, don't take that for granted at all, because they may be suffering greatly, especially if they're immigrants in a community that's predominantly Muslim, because they want to be in a place that understands their language, but their entire community is completely different than what it was in the Middle East. So it depends on the circumstances. It depends if they're voluntary and they came here voluntarily to create a better life, or they came here because their communities are rampant. So it's a very difficult and nuanced question. And there is research on that. I just don't have it on me right now. We did publish a paper a few months ago through the MOVE team. And it discusses some of these topics in it. So I could leave the name of that in here.
Wonderful. Well, thank you for sharing that. And also thank you, Yasmeen, for taking the liberty to sharing your gut feeling. Say, hey, I live here and this is what I see and this is what it is based on. Thank you for making yourself heard. I do see a couple of raised hands, but before that, there's also a few questions that were in the chat box. So the next one, family support is important to mental health recovery. How do you think a support system in the family can be developed when shame and honor is involved? And again, I would like a woman's perspective and a man's perspective on this one.
No, go ahead, Yasmeen.
Sorry, I'm just rereading the question.
Oh, how can you develop a family support system where you're coming from a shame and honor culture?
I think what we were talking about before, in that the community ties are so strong with the honor shame culture. I think that is an advantage, because then even more so as a family, you can come forth and show your support for that person who is suffering, because that it is natural for the family to be involved. In terms of a female perspective, if it's a mom who's able to, possibly come with their child to therapy appointments, or keep an eye on just how they're doing on a day-to-day basis, possibly come into even the medication appointments and just tell the provider how they're managing. I think that is the best way within an honor shame culture, is just to keep the family involved in the most positive way possible, so that they're not going through it alone.
So and it's a double-edged sword in honor and shame families, because honor and shame families are more involved. So they're more involved in their kids' lives. So they may tell them what they want them to do, what they want them to be when they grow up, what they may structure their life for them so that it brings the most honor to the family. And that could be a double-edged sword. Involvement can be a double-edged sword, because they may be the ones that push them to go to treatment, but they may also be the ones involved in keeping them from treatment, so that their business doesn't go out there. So the best thing I think we can do is just to provide that education in a culturally appropriate way, so that we invite people to treatment instead of scaring them away from mental health, and making sure that we are using the cultural framework of honor and shame that may be that's a neutral framework, right? Culture is a neutral framework, but so a neutral thing can go wrong or could go right, and to kind of push it to the right way. Yes, we want family involvement, but we don't want the family involvement to be dictated to the kid. We want the family involved in the wrong way. We want the family involvement to encourage the treatment, not discourage the treatment. Because if we encourage treatment and they get better, then guess what? The family's honor is preserved. So you preserve the honor of the family, but you've done it in a positive way. While if you discourage treatment, yeah, the honor may be preserved because nobody knows anything, but the family's fallen apart.
That question was from Diane Mitchell, and I have a one-word question from the next person in the chat, and then I'll go to Heba. I see she's raising her hand. So Allah Muhammad is asking, she's saying, this was very well done and such an important topic. Do you plan to publish your research?
Okay, so we are presenting on behalf of MOVE, which is an organization that is based in Dearborn, and we are looking to publish research. We did have a paper published last month about depression in the Arab American community.
A couple months ago.
A couple months ago. And so based off of the case studies that we have now, and we're also looking to build up on that, just in various Arab American communities, we will look to publish once we compile all of the data that we're looking for.
Some of the things we're looking at now is just perceptions on telehealth within the Arab American community, and has that been something that they see as equal to beneficial or worse than inpatient?
About it too, not just the Arab American community, but the entire Muslim community as general, where people come from an honor and shame culture. If being able to do a telehealth appointment from the comfort of their homes would be something that would be a lot more convenient than needing to go out, go to an office, and then be seen within the community as someone who's really private.
Yeah, I'm interested to see, because my gut feeling tells me that they actually prefer inpatient visits, because they all been asking, I actually want to come in. So I've been that's what sparked it in my head. I'm like, I would have thought the opposite. So I want to see what the numbers say. So, but it is interesting, yeah, because you would think that this would be a godsend, right? Like finally we can just do this from home. But I mean, a lot of even the ones that come specifically to see me, who are pretty renowned people in the community that come for appointments, they want to actually come to the clinic and see me, but they want to come in and not sit in the waiting room, but they do want to come in. So they come in, we have a special room that people who want privacy can sit in. But yeah, so it's been really interesting anecdotally, but I'm interested to see what they actually say on paper.
Look forward to it. I'll go to Heba. Heba, please go ahead and ask your question, and feel free to turn on your video if you'd like.
Thank you so much. Thank you both for the presentation as well. I actually typed in one question, but because I had another one, so I kind of like chose to raise my hand so I could like paraphrase the first and then like go on to the second. The first actually is kind of long, but I'll try as much as I can to paraphrase it. Basically, it's about the categorization overall of like, like honor and shame versus dignity. So this categorization seems like it's new to me personally, to be honest. But it seems very much related to collective versus categorizations. But to me, the second categorization, I mean, like collective versus individualistic, is kind of like more, and seems to me that it's like kind of logical more than the first one, or not logical. Let me see, agreed upon, like taken for granted, let's say. So the first one, like honor, shame versus dignity, guilt, is I felt this controversy mainly when Miss Yasmeen, thank you so much for the example you gave. It was actually great to give the example of Christian communities within the Western world, and how even though they are religious, they identify as religious, but they still are kind of more free and kind of different than Muslim religious communities in terms of that they don't really care about how people perceive them. They don't care about, kind of honor and shame kind of aspect. There's no such aspect in Christian communities within the Western world, even though they're Christian, even though they're religious. So my question is, I mean, I see the point in Christian communities, but I also think it applies to Muslim communities. I know it's different in terms of culture. I mean, Islamic how can I say it? I actually wrote it. Muslim majority culture is kind of more impacted by the doctrines of Islam more than, I mean, yeah, in Christianity, it's like it's kind of prohibited to. I'm not sure about the specific legislations, but some things that are prohibited are actually practiced by some Christians. Yeah, they identify as Christian, but they still practice prohibited things. Whereas it's rare to see in Islamic communities. But still, the main question, I'm trying to go back to the main question, which is it's still like there's the free will of the Muslim individuals within the Muslim populated cultures to go back to the original text, to the Quran and Hadith, and see that it's actually not about how people perceive you. I mean, it's so much emphasized in the Quran and Hadith, and I guess we agree upon this. It's always the case that no, it's important what Allah thinks of you. It's the most important is what you have in your heart, your intention. Sometimes people would think bad of you, but it's if you're not doing something wrong, you should be confident on all of this stuff. So I guess there's like kind of we're reducing the free will of Muslim individuals or the capability of Muslim individuals to go back to these original doctrines and texts and see how they are based on dignity, guilt, rather than honor, shame.
So I would like to just jump in on this real quick. So there's a couple of things. So Islam, religion and culture they go together. It's not that religion is in any society, realistically, clinically, they are symbiotic. So a culture doesn't necessarily adapt the entire culture that the religion promotes, and vice versa. This is realistic. What is interesting is that we're looking at honor and shame in a negative context, and I'm trying to look at these things from a neutral context because they exist, right? And if they exist, we have to respect that they exist. I really appreciate the conversation because it's such a meaningful topic, but it's so important that we recognize that they exist and to look at them as neutral, separate frameworks. And there's overlap with everything, right? And there's also a third culture that's like based on face, saving face, and things like that that's found in the Far East. What's interesting about the Quran is that it uses both many different things to promote behavior. So it does use issues of honor and shame when it talks about the Day of Judgment, and some people's faces are going to be yellow, or they're going to be disfigured, or they're going to be embarrassed. It talks about that even with ghiba, that if you talk about people, you're going to be eating them in the hellfire. So it uses strong imagery to discourage certain behaviors. And so it uses imagery of honor and shame, and it uses imagery of dignity and guilt, right? It uses imagery of that at the end of the day, it's what God thinks. It's at the end of the day, it's what Allah has provided us with, and piety and those things. But it also uses the notions, especially in the Hadith and the Quran, of honor and shame, because honor and shame is something that exists. But when we are thinking of it from a Western viewpoint, we think of it as a negative thing, when it should be looked at as a neutral thing and used to help our patients through their therapy and through their psychiatric care and through their mental health, instead of admonishing it. Because what happens when you admonish it is it's very hard to get any type of a positive outcome. Instead, you're kind of creating a fantasy for the patient, telling them to do you and be you and all that, and they're not going to be able to do that. So you have to be realistic sometimes when you're doing the certain treatments. As far as the collective versus non-collective, the reason I don't like to go through that model is because there's way too much overlap and too much categorizing, because there's, are Arabs all collectivists? No, not really. I mean, if you go to Cairo, for example, it's very individualistic. If you go to the villages, it's more collectivistic. England, the UK, for example, has a strong culture. It's one of the few in Europe that's based on honor and shame, yet they're very individualistic. So the collectivist individualist thing, I think it has a role to play, but I'm more interested in the actual framework of the culture. So that's why I look into the honor and shame and dignity and guilt, because I think that these are they're neutral, they're equal standings in the world. There's just as much people in one as in the other, and it helps create where the moral compass is coming from. While collectivists versus non-collectivists, I mean, even in America, you see collectivism and tribalism and things like that in many aspects of our culture here. So I like to look at the value base of the culture. And that's why I really got attracted to the honor and shame, dignity, guilt, and face cultures. So that's where I'm coming from. And I'd like to also hand it over to Yasmeen to also give her viewpoints.
Yeah, well, I think with the idea that the Quran should be how Muslims conduct themselves, obviously that is true, but the reality is that the cultures are still separate from what the Quran says. So even if, you know, we're being told that we are living for God, people who are suffering aren't going to see it that way. And then things that might be inhibiting them or encouraging them within the honor culture or the honor shame culture framework, that's going to be separate. And no matter what, we have to work within that. I don't know how much religion really has an impact on the culture itself.
Another thing with honor and shame that's prevalent is the status of parents, parental figures. In honor and shame cultures, parents have a strong standing, right? And you know, Islamically, even with the Quran and the Prophet, when he talks about the honor of the mother and the honor of the father and these things. So, like I said, religion often encompasses both things because religion is usually eternal and infinite, and so it's going to encompass all the human experiences. It's how we are able to go through that and find what is actually being done and what is not. And that's what makes us clinicians, and that's why we have to be neutral when it comes to cultural frameworks in my experience.
Well, thank you. Sorry, were you going to say something, Heba? Go ahead.
Actually, I do have elaborations, but I would like to allow my other friends to ask their questions. So
Thank you.
I will thank both of them for their answers. It was enlightening.
Thank you, Heba.
Thank you very much. And I just wanted to make a real quick comment on that and go ahead and say, I think it's very interesting, Heba, that you brought up. It may not be as black and white as honor and shame separated from dignity and guilt. Maybe there is a whole lot of gray area, a whole lot of overlap. And I saw a very interesting comment in the chat section while you were talking, Shady. There was a comment made up that, well, to differentiate whether it's religion, whether it's culture, it'd be very interesting to do a study of like Arab Muslims versus indigenous Black Muslim population and see if African-American Muslims versus Arab Muslims are any different in the way they respond. With this, I'll go ahead and go to Rachel. I know you've patiently been waiting a while. Go ahead and ask your question, please.
Thank you, and thank you very much for the presentation. I mean, my question relates, I guess, to the area or the overlap, because I've been thinking about young people I work with where they feel really caught between those two frameworks. So they may have been born in the UK or come when they were very young, and their family be very much aligned with the kind of honor shame framework, but then they are at school in a very diverse community and here in the UK, in London, and they may feel not integrated yet. They're still really struggling with their identity. And so I'm wondering, when you're working with young people like that, where they're caught between these two frameworks, what do you recommend as the best ways of pitching that?
Well, the first step is to recognize that integration and acculturation in general is not it's not easy, right? It does cause it's basically identity. You're forming an identity, a new identity, depending what age you came. You may be forming that new identity at the age of 30, age of 40, or the age of 10. So that's the first thing, is to recognize that. The second thing is to normalize that's going to happen to the person. So if you're working with someone and they're telling you they're struggling, to normalize that struggle, instead of looking at it as a negative, look at it as something that's bound to happen, because anyone who goes from one culture to another is going to struggle a little bit. And it's funny, it's interesting, because in the research, the UK has a strong honor and shame system. It's one of the few in Europe that has honor and shame, but it presents differently than the honor and shame of maybe India or Egypt or Lebanon or what have you. So there is a lot of gray, definitely. But I think to normalize that, to understand that, to help your patient or client understand that that this is something that's going to happen, that you are to explain and teach. Psychoeducation is such a powerful tool to educate on that. It's so important for me. Just anecdotally, is I grew up in Dearborn, Michigan, and then in 8th grade we moved to Livonia, Michigan, and it was a very different culture. So I went from a predominantly Middle Eastern school to a predominantly white school, and so I struggled with that for about 5 years, up until I graduated high school, on what my identity is. Am I a Dearborn bro, or am I someone from Livonia now? So and even the way people talk and dress and act, and the things they hold dear is very different. One is not negative and one is not positive. Coming from one culture of honor and shame, that's not backwards, and that's not terrible, that's not evil. Just like coming from a dignity culture does not mean that you're completely aloof and don't care about anybody and don't care about what people think, right? So but that move for me from predominantly Arab to predominantly white was very, very difficult. And I think one of the reasons I went into psychiatry is to figure that out. So it's just difficult, and it's going to be difficult. The best thing we can do is provide the support and get them the care and to psychoeducate on what is going on. One of the things that helped me was when I was in 11th grade, I was taking a psychology class, and they went through the process of acculturation. So just learning about that really helped. So that psychoeducation aspect really helped me navigate. So I think we have to take that into consideration. Psychoeducation is a very powerful therapeutic tool.
Okay, thank you. And I guess a lot of these young people are moving through, it's not just moving from that to this over one long process. It's every day they're moving to and fro, I think, from home to school and into other environments.
Thank you. I think you might have cut out a little bit towards the end, but do appreciate your question. And now I'd like to call upon Farasheen, who's also been waiting for a while. Please go ahead and ask your question.
Okay, great. Thank you so much, and Assalamu alaikum, an excellent talk. So very briefly, my question was, how do you both recommend handling situations in which there can be a potential conflict between traditional ideas or concepts of honor and shame, and then personal safety? And I highlight instances of, for example, domestic violence, as well as child abuse.
One interesting thing regarding domestic violence and child abuse is that they are very similar across all cultures. Dignity and honor and shame cultures, they're very similar. The only specific difference would be the person reaching out for help or not, and how they reach out for help. So in an honor and shame, they may go to a cleric to reach out for help. So we have to educate our clerics and imams, but they both reach out for help, and they both suffer at the same level, or statistically similarly across all spectrums. So immigrants, non-immigrants, whites, non-whites, they suffer from domestic violence at equal rates. So oftentimes we hear about, people disparaging Arab or South Asian or et cetera households which have domestic violence, and it's inexcusable. But we have to also recognize that it exists across all cultures. And dignity and guilt cultures, it may be that someone is doing them and they're trying to be unique, and they're drinking and coming home drunk and then beating their families. In honor and shame culture, it might be the wife said something in public and upset the husband, so he hurts his wife, etc. So the reasons might be different, but the statistics across cultures is that it's almost the same. It's very similar across all cultures. What it is we have to educate our imams on how to address it, because those are the ones that are going to be getting the complaints first, usually. Imams, and if they come from so Iraqis have tribes. Tribal affiliations. It's not tribes per se, but they have tribal affiliations. So the tribal leader should, whoever the boss of the family or the big person or the patriarch of the family should be involved. In matriarchal societies, whoever the matriarch of the family should be involved in alleviating the problem. So oftentimes villages have, a lady that with high amount of respect that people go to for these things. But you know, in the US specifically, imams need to be educated on how to approach this topic, and how to provide help, and when they need to report and when they don't need to report to CPS, etc. This is extremely, extremely important. But as far as people reaching out for help, they do reach out for help, and they suffer at the same rate as others, and it's terrible. And if they reach out to help to an imam who doesn't know what they're doing, then it's not going any further than that. So we have to educate them. You know, I've had stories of people going to imams, and you know, the prescription was patience. Be patient, be patient. Well, that has nothing to do with honor and shame culture. That has nothing to do with our culture. It has nothing to do with religion. That's the imam being ill-informed, right? So, you know, we have to also educate them on how to give healthy support, and also understand where their limits are so that they can refer out.
Just from what I've seen, when it comes to support groups for people who face domestic violence or abuse, regardless of the background that they come from, if it's a honor shame culture background or dignity guilt, Jewish, Muslim, white, Arab, the support given is the same all across the board. I think the only difference comes for honor shame, worrying about what the family is going to think of you if you leave your spouse. That might not be as much of a concern in a dignity guilt-based culture, but the way that the help is gone about for anyone is the same.
Thank you so much. We're getting ready to the close of our session. It was a great discussion. Before we end, wanna give each of you 30 seconds for closing remarks, and then we'll go ahead and end.
I actually just wanted to end just based off of something that was said earlier on about the telehealth, actually. I'm just trying to find it real quick. Someone had said that maybe the people prefer to leave the home because of what they face at home, and it's easier for them to get away from that. That is something that, after personally talking to therapists at the clinic, that is the case. It's easier for them to have a safe space outside of their home to come to, because within the honor shame culture, the people around them in the home are more pressing. So I think that I just want to end by saying that that's something that we definitely want to look into as well, seeing both the advantages and disadvantages of telehealth overall. So.
I'd like to close by saying that we have to be truly culturally appropriate and sensitive. It's not enough to say that we promote diversity, but only if it all is the exact same dignity and guilt-based culture, right? No, we have to promote all of it. We have to understand that these are neutral ways that cultures are upbrought. Religion is a force in many cultures, in many regions around the world. But religion seeks to give us something to worship, to a goal and for the afterlife. But it doesn't come in to say, you know, replace and get rid of everything that the culture has. No, but it tries to reframe it. And we have to be realistic when we're dealing with patients, not to project our own either experiences with a given culture, or project our own negative reactions to certain words, because certain words are often used in a negative connotation, and to really be there for them and try as much as possible to use their frame of reference for a therapeutic relationship. That's what empathy is, really putting yourself in someone's shoes. So this is something I care deeply about, and so I hope you guys got something out of this, and I look forward to further discussions.
Thank you so much. Thank you for the excellent presentation, both of you, and for your patience in answering all our questions. Thank you to all the attendees for such active participation. I think it was a wonderful, wonderful session. This also brings to end our last academic session for this conference for Track A. What a beautiful way to end. Please do join us for our closing remarks, which will be on another link, which will start shortly in about 8 minutes or so. Thank you again, everyone, for coming. Assalamu alaikum.
Thanks.